Welcome everyone to Mamadospr Medical Media, a free online YouTube channel, weekly posting new medical videos. Join our Facebook and Telegram groups for more interaction and latest news. You could also support the channel on Patreon, where we upload multiple choice questions and other premium content. Thanks in advance.
Hi again. In this video, I'll mainly be covering pulmonary embolism, but you can't talk about PE without mentioning its other half, deep venous thrombosis. I'll go over the essentials, clinical features, investigations, treatment and prevention. Deep venous thrombosis, or DVT for short, goes by another name sometimes, venous thromboembolism. It's due to formation of a thrombus in the deep veins of the lower limb and the pelvis, mainly the thigh. It can happen in other areas of the body, like the upper limb, but that's rare. Its risk factors can be divided into three categories: hypercoagulability, like in pregnancy, the use of combined oral contraceptives, protein C and S deficiency, venous stasis, like being immobile for 3 days, obesity and surgery, and blood vessel injury, like in hypertension. Together, we call it the Virchow's triad. A person with DVT will mainly present with inflammatory symptoms on the affected limb, such as swelling with pitting edema, tenderness, hotness, and redness. The investigation that we do first is the proximal leg ultrasound. If it's negative, we do a D-dimer. Make sure that the patient is anticoagulated while waiting for the test to be done. In treatment, the first line is direct oral anticoagulants like apixaban or rivaroxaban, because they've all been proven to show less risk of bleeding and work quickly without needing to use an IV anticoagulant. Low molecular weight heparin is used if oral anticoagulants are unavailable. Unfractionated heparin is used in those with renal failure or have a high risk of bleeding. And lastly, warfarin is used if all else fails. To prevent DVT from happening, the patient should mobilize early after surgery. If they're on any oral contraceptives, this should be stopped 4 weeks before surgery. They should wear compression stockings, and in high-risk patients, they should be anticoagulated with low molecular weight heparin. Now, our main topic, pulmonary embolism. We'll look at the essentials of PE, risk factors, signs and symptoms, 2-level PE Wells score we use to calculate the likelihood of PE, investigations, management, and PE in pregnancy. PE is an obstruction of the pulmonary artery due to an embolism that's usually secondary to DVT. The embolism is most commonly due to a thrombus, but can also be due to fat from a long bone fracture, air from neck cannulation, or amniotic fluid. It usually starts off as a thrombus in the deep veins of the lower limb, and a piece breaks off and travels up the common iliac vein, the inferior vena cava, before entering into the right atrium. It would then go into the right ventricle along with the blood before being pumped into the pulmonary artery to eventually get lodged and block the blood flow. The risk factors are what predispose the person to developing PE. They're quite similar to the risk factors of DVT. We use the mnemonic embolism, E, existing DVT, M for mobility, as in those who are immobile during long flights, B for baby, meaning pregnancy, O is estrogen, meaning combined oral contraceptives, L is large, as in obesity, I is immune diseases like thrombophilia and protein C and S deficiency, S for surgery, and M for malignancy. The symptoms of PE are non-specific. They can sometimes be asymptomatic if the emboli is small enough, or fatal, causing sudden death if large. They present with sudden shortness of breath, pleuritic chest pain, cough, and hemoptysis. Signs include tachycardia, tachypnea, hypoxia, fever, raised JVP, and in severe cases, hypotension and cardiogenic shock. On auscultation, you'll hear a gallop rhythm and a pleural rub. The 2-level PE Wells score is used to calculate the likelihood that this patient has PE. We use the mnemonic, cannot treat if PE helps me. C for clinical suspicion, as in they're showing symptoms of DVT or PE. N, no other diagnosis, so you've ruled out other diseases on your differential. T for tachycardia, I for immobilized, P for prior history of PE, H, hemoptysis, and an M for malignancy. The top two are 3 points, the middle three are 1.5 points, and the bottom two are 1 point. If they've got less than 4 points, PE is unlikely. If more than 4, it means it's likely. The investigations we use in these patients are, we do blood tests like CBC, looking for infections, clotting profiles. ABGs might show low oxygen saturation and respiratory alkalosis. Chest X-ray to rule out other diseases. ECG will show sinus tachycardia. CT pulmonary angiography, D-dimer and VQ scan are specific tests, with CT pulmonary angiography being the most accurate and gold standard. VQ scan is only done as an alternative if the patient has renal failure, is pregnant, or is allergic to contrast. In a suspected PE patient, we would calculate the Wells score and put them into two categories, either likely if they've got more than 4 points, or unlikely if they have less. If they're unlikely, we do D-dimer, and if it's positive, we'll confirm with a CT pulmonary angiography and put them on empirical low molecular weight heparin if there's any delay in getting the CT done. If negative, then it rules out PE and you look for another diagnosis. Now, if PE is likely, we confirm with CT pulmonary angiography and give the patient an empirical low molecular weight heparin if it's not available straight away. In managing these patients, our mainstay treatment is anticoagulation, but first we must resuscitate them by giving IV fluids, oxygen if they're hypoxic, and analgesia for the pleuritic pain. For anticoagulation, we give them either a low molecular weight heparin or fondaparinux, and in cases of renal impairment and chronic kidney disease, we use unfractionated heparin. Thrombolysis is used if they're hemodynamically unstable, and if the blood pressure keeps falling after thrombolysis, we'll give them a vasopressor like dobutamine or noradrenaline. Pregnant women are constantly at risk of developing PE, seeing as the pregnancy puts them in a hypercoagulable state. PE is the leading cause of pregnancy-related deaths in developed countries, and the risk increases postpartum, especially if they underwent a C-section. In these patients, the initial test is a chest X-ray to rule out other diseases. Seen as in PE, it's usually normal. This will help us decide on what to do next. If you suspect PE and the X-ray is abnormal, you do a CT pulmonary angiography. If it's normal, you do a VQ scan. Both tests can pose a risk for both the mother or the baby, but the risk is only very minimal.